And we're live. Dr. Kris.
Hey,
how
Steve.
Are you?
I'm good. A little under the weather, but nothing too bad. Nothing going to keep us from podcasting, right?
No, we're professionals, even though we're older and all this tech exists. Look at us. We're showing up. We do the work. We're excited to see you again. It's been a while. Today, we're talking about hormone replacement therapy after menopause. Menopause.
Or pros, whichever.
That's a new version.
You're going through menopause and have brain fog, right?
Exactly. All right, I'm going to roll our intro. Here we go. Let's see here. I'm going to pause our music, and here we go. If you're like most folks Dr. Kris Fusterhausen works with, you're active, you want to take ownership of your health, and you want to age gracefully. The problem is there is so much conflicting information out there about health and wellness, it's tough to know who to trust. Most providers are limited by what insurance will approve, so it can seem like they're only able to help you manage your health decline with more meds. On the Dr. Kris Life Podcast, you'll learn how you can regain your confidence in your health journey. You'll learn helpful knowledge about programs, supplements, peptides, and hormones that Dr. Kris has used with thousands of patients just like you to help them crush their goals and be their best selves. So if you're ready to take charge of your health and are wanting to stay active and healthy so you can be a better parent, partner, or lover, then you're in the right place. Welcome to the Dr. Kris Podcast. All right, we're going to talk about hormones today, hormone replacement therapy after menopause. A lot of women have this. It's amazing when the things that women go through when they don't have this dialed in. Your wife has a great story as well. So, Dr. Kris, tell us a little bit about this topic.
Well, so it's probably one of the most common topics that we discuss here in the office, and it's menopause, hormonal imbalance, menopause. Menopause, of course, is when ladies stop the ability to make estrogen, also combined with, if they still have a uterus, the lack of menses or period. So many women, I believe, think and it is, of course, normal to go through menopause. Average age of menopause, 48 to 52, but that doesn't mean that that's the only time it happens. Some women go through it earlier. Some women go through it later. Like I saw a 56-year-old female the other day who was not menopausal, so it can happen later in life. But the thing that I hear the most that is always so concerning to me is it's just something I have to deal with. It's just natural. It's normal. Nothing really can be done about it. The things that can be done about it are too dangerous. If I do take something like hormones, I can only do it for 5 years. These are some of the common myths that I hear in my office that then we try to take a few minutes to dispel and then try to talk our patients through why it's important that we treat those conditions. But yeah, you talked about my wife, Chrysanta. Anybody that knows me probably knows my wife. And on her 48th birthday, I always tell the story because she's now 51, and it was during COVID, and it was on her birthday, and I come in, and we were at home because it was kind of when COVID had started, and it was the day that we got off early or something because, early on in COVID, we were all kind of like at home a lot more. And she has her head in the freezer. And I always say, I was like, what? And people that know me well know I tease her. Sometimes she can be a little histrionic, in my opinion, And I said, it's just because it's your 48th birthday, you think you're menopausal now. And she's like, no, that was a hot flash, and it was miserable. Sure enough, we checked her blood work the next week. She was menopausal. She was absolutely not being histrionic. She was for real. And so up until that point, obviously I'd been treating ladies with menopause, but I had never lived with one, much less shared a bed with one. And so it was very eye-opening as a spouse to see what a person's going through with those type of disruptions in their hormones. And of course, she let me know about it pretty much every day, what she was going through. And so we worked on getting her fixed. And, I learned some really good lessons through that we can go through at some point if you want to, about estrogen. And so it was just very eye opening to be, there side by side with a person on we work together. So damn near 24/7 basis watching them go through menopause.
So, what is it that happens with women's hormones during and after menopause? And I ask this sincerely because sometimes we don't notice incremental degrading of our health until later. And so to know what these symptoms are, help us not feel crazy, right?
Yeah. And so, what is menopause? Menopause is the loss of the ability to produce estrogen. Now, that doesn't usually happen overnight, although it can be, usually that's a slow progressive process. But then you finally hit the point to where it shuts off, and a person like Crisanta gets the actual first vasomotor symptom, which is a hot flash, which, by the way, I want to talk about what is a menopausal hot flash. Of course, this is how I've been told.
Yeah.
Please, no women throw darts at me figuratively, because no, I've never had a menopausal hot flash. Okay. But the best example that I've ever been told, and every time I say this to a female, they're like, yep, that's it. Take a wood match, and we've all lit a wood match and watched the red tip get super hot and then flame up and then eventually go away. That's typically what women experience with a actual menopausal hot flash, like a wood match lighting. The red tip in their chest to their head dissipates, occurs over just a few seconds. But obviously, if you could imagine what that might feel like, probably not so good. So some of the symptoms that women will start to feel is they can feel like they're going crazy. I always joke when I say that figuratively, but that's kind of subjectively what they come in and tell me. Like, I just feel like I'm losing my mind. I feel like I've become ADD. I can't get tasks done. I'm fatigued. Sex life is suffering. My libido is poor. Vaginal dryness. That's another very common. The two quickest questions I ask females is, are you having hot flashes and or vaginal dryness? So the vaginal moisture that they normally have starts to go away. That obviously for a female can affect sexual relations and or intimacy and the pleasure associated with intimacy. Sometimes metabolic changes like weight gain, starting to gain fat, lose muscle, trending towards that sarcopenia that we always talk about. The list really goes on, but those are kind of the most common things. Then those are enough, right? For somebody to be miserable. If you're fatigued, gaining weight, don't sleep good, don't like sex that much, vaginal dryness and hot flashes, that'll drive most females into the office at that point.
I remember the commercial on TV back is that low T, low testosterone, but there's a women's version of that as well. And what does the studies say about certain therapies that can support this? I think a lot of women, when I've happened to just kind of discuss it, it seems to me a lot of impressions are that the things that you take are synthetic, and that there's a short window of time that they're effective, and it could lead to worse outcomes than what you're hoping to improve.
Well, so the first thing we want to talk about is that not all hormones are the same. And so this topic is a broad topic. And I always tell the story that when I reboarded for my family practice boards 5-6 years ago, I had to answer a question incorrectly, which still bugs me today because the question was incorrect, but I knew what they wanted in the question, right? Mm-hmm. And the question was, estrogen replacement therapy is associated with what? And they wanted me to circle increased risk of breast cancer, strokes, and heart attacks. Okay. And I actually skipped it. I got to the end of the test. I came back and I'm just sitting there and I'm like, I'm pretty sure I'll pass even if I don't answer this question. But I was like, screw it. I know what they want. They want me to do this. The problem with that is so that's the mantra that we hear a lot, that estrogen increases breast cancer, strokes, and heart attacks. Okay. Well, first of all, estrogen's a broad topic. What kind of estrogen are we talking about? Are we talking about bioidentical? Are we talking about synthetic? Are we talking about animal-based? What are we talking about? Okay. That's like saying, all pickups have this particular problem. Well, that may not be true. Fords and Rams may not have the issue a Chevy does, or vice versa, whatever. So many years ago, this study came out by the Women's Health Initiative, and it basically, they used Premarin and Prempro, which is equine estrogen and progesterone, or just estrogen. And they saw this increase in strokes, heart attacks, and breast cancer. Okay. And basically, immediately, all doctors, or most doctors, stopped prescribing hormones. This was really kind of at the cusp of when bioidentical hormone therapy was starting to come into a trend. So it scared everybody. There are doctors today that I still hear telling their patients that estrogen is dangerous. It just drives me crazy. But anyway, just means our job is not done. Okay. They actually, believe it or not, retracted that study a couple years later, because the study was very flawed. And even the people who did it admitted it later and retracted that study. But the damage was done. There are doctors today that still don't know that study was retracted. They also don't realize that all the studies that have come out since then, when you look at bioidentical estrogen, and what is bioidentical, in case someone's new to our podcast and doesn't know, bioidentical, the name says it all. Bio meaning natural, identical to what's in your body. So it's plant-based estrogen, basically. And the estrogen is exactly like what's in our body. It's not synthetic, and it also is not from an animal. Okay. And so I think it makes good common sense. I'm a big common sense kind of person. I think that if we use common sense in our life, we'll probably be okay most of the time. And what I tell my ladies is, and we'll get to the studies in a second, but if I'm just giving Betsy back what Betsy had her whole life, exactly like what she had, and actually not even at as high a levels as Betsy used to have, how is that going to cause more problems? Somehow her body for 48 to 52 years was fine with it, but at 50, it decided, nope, it's bad, and now I'm going to react to it differently. Let's not be silly. Our bodies are smart, but they're not that smart. Okay. And so we're just giving patients back what they've lost. The studies prove I think breast cancer is the best one to talk about. Okay. And most of the time we use, for hormone replacement for females here, we use bioidentical pellet therapy. And the company that we work with is called BioTE, BIOTE. What does that stand for? Bioidentical testosterone and estrogen. Okay. So that's actually what, and by the way, let's not lose sight that women need and have testosterone just like men have estrogen. Okay. So in menopause, testosterone is just as important as estrogen, but we're really having an estrogen driven discussion here because it's the one with menopause that goes. But the studies with subcutaneous pellets with testosterone and or estradiol show a 40% reduction in breast cancer in women. 2 large long-term studies have shown the same thing. We lower the lady's chance of breast cancer 40%. So that's the first question I always get is, oh my God, you're going to give me breast cancer, aren't you? And I say, well, you can still get breast cancer. That's possible, but 40% less chance with what we're going to do. We still need to make sure we're getting our screening tests done and keeping an eye on things, making sure. And if you do get breast cancer, we need to reevaluate this, but we're lowering your chance. We're also lowering, your studies are proven, we're lowering your chance of heart disease. We're lowering your chance of strokes. It's probably the most common topic I get into with guys. They're cardiologists. I have cardiologists out there still telling guys that proper testosterone therapy is going to cause them to have a heart attack. And that is simply not true. Thank God at SSRP, we have a faculty member, Abid Hussein, this amazing cardiologist up in Denver, who that's what he lectures on, the safety of hormone replacement in the heart. But so the biggest things the studies show, oh, heck, I forgot maybe one of the coolest things. So bone density, and that's all. Heck, we should probably do a podcast on bone density. Okay. So maybe we can remember that together, but I have something I always like to say. First of all, is that we don't want to lose muscle mass because that's called sarcopenia, and losing muscle mass. Muscle is the currency of aging. Another thing I would like to say, in my career, I haven't seen anyone with great muscle mass and bad bones. If you have muscle mass, you'll keep good bones. But let's pretend we have a patient who has osteopenia, That's the early stages of bone loss or osteoporosis, is where they're actually considered truly diagnostic for too thin of bones. The most common way that is treated is with the bisphosphonates, which are these medications that have a lot of side effects. Guess what actually causes patients to grow just as much bone, probably even better, without all the side effects? Hormone replacement, bioidentical hormone replacement. So I always say, if nothing else, we're lowering your chance of dementia, increasing your bone density. We are lowering your chance of strokes, heart attacks, and breast cancer. And oh, by the way, we're making you feel better at the same time. We're making the hot flashes go away. We're making your vaginal dryness go away. We're making your skin look a little better, because estrogen is very important for collagen elasticity as we age. There's a reason why women say, I really started to show my age when I went through menopause. It's not the age, it's the fact that they lost their estrogen. Okay. That's usually an easy way to get females to say, hey, I can slow down your skin aging. And they're like, oh, sign me up, because no one is really wanting to look older, right? I've yet to have a consult on how to make me look older. And so those are basically the things the studies show, and the safety behind it.
So these studies recently, well, actually, so let's talk some more about the bioidentical. How in the world do they know to make me as a woman, or even a man, how do they make it identical to what I need?
Well, it's natural. It actually comes from the plant. So it actually is, it's kind of it's kind of miraculous that we have things that are natural that are exactly like what's in our body. And so, I guess that's a higher power above us, right? And making things quite similar. And again, I just always go back to, if something is truly identical and natural to what is already in our body, I think it is common sense to believe that those things are going to cause less issues within our body. Like, now, could I give you way too much and have issues? Of course. Could you have something already going on in your body, and when I give you estrogen, it causes a problem? Absolutely. And maybe let's go ahead and talk about that now. Like, what are some of the dangers, right? So the biggest danger with estrogen is if you have a uterus. So in other words, a female who has not had a hysterectomy, we could start them back to bleeding. Okay. And so menstrual bleeding, of course. And of course, so never had a consult for make me look older. I've also never had a female who has stopped having periods, who's actually looking forward to having periods again. So we do usually have an extensive discussion about how, if we give them estrogen, there is this chance. Now, we use things like progesterone to prevent that, and it is not common. But as I was just telling a patient last week, if you do bleed, that can actually be a sign that there's something maybe wrong with the uterus. Maybe you have fibroids. Maybe you have uterine cancer. So as I always say, the bleeding, although can be a not so nice side effect for patients, sometimes it helps us find abnormalities that maybe we wouldn't have found otherwise. So we just don't want to ignore it. This one particular patient, like, I don't think I'm going to get hormones anymore. And I'm like, no, let's not be that dramatic. Okay. Or drastic, maybe the better term. Let's not be that drastic. Let's work this up. Let's figure out what's going on, and let's go from there. And she eventually was like, okay, I understand. And because we could fix that issue, but that's probably the biggest side effect that women are nervous about, is actually restarting their period.
So it's like, all right, so you're gonna put something under my skin.
Mm-hmm.
How often are you going to do it? Does it hurt? Where does it go? What's it look like?
Yeah, so if a female gets pelleted with subcutaneous bioidentical hormone pellets, the procedure takes about 7 minutes. It's in the upper. Typically, we use just the upper butt cheek. We place the incision, which is about 1/4 of an inch long, where it'll be well covered if they're in a swimsuit or something like that. So we know how to make sure, and because if there is a tiny little scar, we don't want it to show. The procedure is practically painless. There is a little stick with a needle and lidocaine being injected, but once that occurs, there's no tenderness after that. Again, like I said, from start to finish, less than 10 minutes. We place the little pellets, which can be anywhere from 1 to 4 for females. All those pellets together are smaller than a Tic Tac. It places up under the skin, and they start kicking in about 5 to 7 days. Those pellets in a female will last anywhere from 3 to 4 months. So the frequency of a female repellet is every 3 to 4 months. Each patient does absorb the hormones differently, and that's based off your cardiac output. Cardiac output's how hard your heart beats and how fast it beats. So let's just say I have two identical twins. They're the same in every way, but one exercises an hour or two a day, 5-6 days a week, and one does no exercise. We would bet that the one who does exercise runs through their pellets a little bit faster than the one who does not, because of the absorption and how it absorbs. And we might even use a higher dose in that patient, even though they're alike in all other ways. And we restrict the workouts for about 3 to 5 days for females. We just ask that they not do lower body workouts. They can do upper body. They can walk. We just ask that they not run or do CrossFit type workouts for 3 or 4 days. We ask that they shower only. They not submerge it in water for 3 or 4 days, and that's it. And then we typically repeat blood work in about 6 weeks. Now, this is an important topic. We repeat the blood work in 6 weeks, and they come in and sit down with myself or one of my other providers, and we go over the labs. But we go over the labs after we've heard how they feel. And what I mean by that is I don't want the labs to skew how you feel. In other words, if I said this is my goal and we didn't reach it, I may have had a patient that felt like they felt fabulous before they came in, but then because when they hear the lab isn't perfect, they're like, well, maybe I don't feel great. Because it is the truth that not every number is the same for every single patient. You need to use your patient's symptoms for how you adjust the hormones. So I always say baseline labs are extremely important for me to get started, but after that, they're just actually markers to see where we're at, but not necessarily is what I'm going to use as the reason why we adjust doses. That's going to be more about the history of my patient at that point. We, of course, want to use labs to make sure we're not in dangerous ranges or that sort of thing, but they're not the end-all once we're actually on hormone replacement.
So how do you know when to re-up? Is it labs centric, or you just kind of get into a rhythm?
You get in a rhythm. So we know that. So that's another common question I get is, okay, so do I come get labs every time before I get pelleted? The answer to that is no. We know those pellets are going to be gone in 3 to 4 months. And so when a patient becomes symptomatic, I know that their labs are decreasing. I don't need labs to tell me that Amy's labs are going away because it's been 3.5 months. Her hot flashes are coming back. Vaginal dryness is coming back. And so what I tell ladies is that typically I repellet my first to second pelleting is usually 3 months to 3.5 months, no longer. And then we see how they do after that. And the patient will determine her own frequency after that. I always say if it's between 3 and 4 months, you choose. So maybe we do 3.5 months from the second to third. Maybe she comes back and says, I feel perfect today. And I'll go, well, good. Then that was a good time frame. If they come back and say, last week I had hot flashes and this and that and the other, and I say, well, we probably need to bump you up to 3 months and a week. So after 2 to 3 pelletings, the patient learns what works for them. And trust me, they will tell you, and they won't go past those dates in the future because they start to feel bad again.
You know, your wife tells this story, and I'll let you fill in all the details, but she had not really had any motivation to get the decorations out of the attic for the holidays or something. And so you guys started on these, and then all of a sudden there was this big change in her motivation and everything.
Yeah. And actually, I think this is a good time to talk about what changes via my wife that it made in my practice. And so I'm very lucky to have a lot of different, I will call them mentors that have been in this industry for many years. You know, we've talked about Dr. Seeds, of course. I think I've talked about Dr. Paul Thompson as well, who got me into this business. And still both of those doctors are very, very influential in my practice, of course. But then, like Betsy Earth, and I mean, we could list a bunch of people, but Uzi Rice, Uzi's he's in his mid to late 70s out in California, and he's written textbooks about estrogen. And of course, Crescenta goes up to Uzi because he's a good friend, and she's telling what she's been going through. And Uzi has this very distinguishable accent, and he's like, more estrogen. And, because of my wife, I became a little more aggressive with estrogen. Estrogen gets this really bad rap, and I'm not sure why. It's kind of what we talked about before. And I think the biggest reason docs go light on estrogen is they're fearful of stimulating a period. And I try to tell my ladies, look, and I have to get a feel for my females. Some are very conservative. And if they are, we'll be conservative right along with them. Okay. But I'm like, hey, this is what we need to do to get you feeling appropriately. And here's one potential side effect that I can help you get through, but it could happen. And if they're like, I'm okay with that, I, of course, document that to remind them later that they said that they were okay with doing this. But I probably across the board use higher estrogen levels than maybe some of my counterparts. And that's because to really get those benefits for the brain and the bones and the sexual health, you need those really good optimal levels of estrogen. We're still dealing with levels that are much lower than when they were in their teens and 20s. We're still not going that high. And again, there is no set number for patients. I just always say, we're going to give you a dose. We're going to test, see what it looks like. We're going to see how you feel. And then we're going to go from there. But yeah, and Crisenta would tell you that her motivation definitely came back, and I always joke she runs laps around me every day. She leaves the office every day after me. She goes to bed after me. She doesn't get up before me, but she does go to the bed after me. Sleeps a lot less than I do, and somehow pulls it off. And she always claims one of those reasons is estrogen replacement therapy.
She's running a practice, and then she's a mother. So running a household and then other things. So that's for her to have that dramatic transition from, like being weighted down with all these responsibilities to being motivated was like I really remember her telling me that story.
And I would probably add a little bit to it. Crisenta has a few times in her life struggled with depression. And the depression was coming back as well. And we had worked with testosterone therapy. We had been able to get her off of antidepressants. And she told me that her depression was starting to come back. And, the good news is that has all taken care of itself as well. So that's a topic we hadn't talked about. Maybe I could spend a minute on that is mood. Is that, studies prove that females, actually, men and women, okay, let's not limit this down to women on this topic. People who have mental illness, and I always try to say, now it's different if you tell me, I've had depression since I was 12 and I've struggled with it my whole life. That's a little bit different scenario. But what I see a lot is people coming in and saying, I don't know why, but in the last 2 to 5 years, I've started dealing with anxiety and depression. And I always ask, I'm like, hey, marital issues? No. Financial issues? No. All the big stressors in life, they're like, no, nothing's different. 66% of those patients will show dramatic improvement in their mood with simply fixing their hormones. And the doctor that started BioT, Dr. Donovich, used to say, none of us are suffering from a Lexapro deficiency. Okay. And I always thought that's kind of corny, but it's good, and I'm not, by the way, some people need Lexapro. This isn't meant to be a jab at Lexapro. But I do believe there's a lot of people taking Lexapro, Zoloft, Prozac. We can name off 15 others that actually just need their hormones fixed. Fix their hormones, fix the depression. But there's a whole chain of event that can occur with all of this that we don't always talk about. You don't feel good. So you go in and they give you Lexapro. Or they give you something and it makes you gain weight and you're not active. And then now, oh, by the way, now I've got a little high blood pressure because I'm overweight. Oh, by the way, now a couple years later, I've got diabetes and now I've got to take medicines for that. When actually, if you went back to the root cause, if we'd have fixed the hormones and got our patient active, maybe we would have avoided all of these prescriptions and all of this negative noise that they now have in their life medically. So I hate to be overly dramatic, but that kind of stuff can absolutely happen over 2 to 10 years. And when actually just go back to the hormones, fix that, start unwinding / reversing all of that stuff.
Wow. So the ideal candidate for someone that might be a good fit for bioidentical hormone replacement therapy would look like what?
It would probably look like anybody listening to this podcast. Okay. and so there's actually very few contraindications to getting all forms of bioidentical hormone replacement. So I just tell patients, look, if you relate to any of the things that we talked about today, man or woman, okay, obviously guys don't get vaginal dryness, but, or biologic males, I guess is what I'm trying to say. Got to be careful with that topic these days. But anyway, if you relate to any of the things that we said, and especially if you're kind of in that 40 or over age range, and by the way, let's back up. You don't have to be menopausal to get hormone replacement therapy, okay? Testosterone replacement therapy. We have tons of females that are not menopausal who do get testosterone, maybe thyroid replacement therapy. So I don't want to limit it down to I have to be menopausal to get hormone replacement therapy. So I just say, if you're feeling tired, if you're feeling sluggish, you feel like your sex life is waning or suffering, if you feel like your brain isn't working right, not sleeping right, you just kind of feel like your best days are behind you, not in front of you, I think you deserve it to yourself to get your hormones checked. And if you're not even in my area, get them checked by a qualified practitioner. Because that's the other thing I get a lot of is people saying, well, my doctor checked and he said or she said my hormones were fine. The first thing I say to them is, can I see those labs? And probably 9 out of 10 times I'm like, I have to respectfully disagree about the opinion that you got. And then we'll sit down and have a real consult about those. So making sure that whoever's, you could bring me, I don't know, a building plan for a building you're going to try to build. And I'll give you my opinion, I guess. Now, is it worth anything? Probably not. Okay. So, you got to make sure that people who are reviewing your data know what they're talking about. And I know they're a doctor, so they should know. No, they shouldn't. Okay. What I wish more doctors would do or providers would do is just do this, the blanket statement of this isn't my specialty. You probably should talk to somebody who knows more about this. I've learned that lesson a long time ago. I have no issue saying it's not my specialty. I don't believe all doctors are supposed to be all knowing about every topic when it comes to medicine. It's just not realistic.
So you mentioned sleep, and that's something you haven't really talked about, but something's really important. And this can improve or potentially impact your rest?
Yeah, absolutely. I mean, your sleep disruption absolutely occurs with menopause and with just hormone imbalance. And sleep is one of the hardest things to treat. So I'm not, any provider listening to this, I'm not trying to sit here and say that sleep is easy to treat, but it starts with hormones and there's many other steps to it. If this is a patient listening and you're going to do something like this, and you have sleep issues, I absolutely recommend sleep monitoring. Spend the money, buy something that monitors your sleep accurately. The two that we really like is the Whoop strap, and we like Oura Ring. As I've said, I have no financial ties to those companies, but I know they're accurate. They work well. I use the Oura Ring. I monitor my sleep every single day. That way, if I change something, I have objective data to see the improvements or worsening of my sleep so I know if it works or not.
Wow. And so if a guy's been listening to this conversation, what would you say as far as the hormone replacement therapy?
Yeah, so it's crucial for guys too. And if maybe you listen to this topic because your spouse you think needs this, many times what we see in our practice is wife comes first, guy comes second. And that's because wife gets hormones, feels great, libido comes up. She's maybe wanting to re-engage a little bit more into the sexual side of their relationship. And now maybe the guy feels like he's not up to par. It just isn't true that we have to let things deplete hormones and just live with it. They're safe. They work. I know TRT, testosterone replacement therapy, can be very confusing to men because you just listen to terrestrial radio, one commercial break, and you'll probably hear 2 radio ads, right? I mean, heck, we have one in a Metroplex. So the biggest thing is just finding a provider you feel comfortable with. And I know the one thing that we do very differently from most hormone practices, and that is that we educate, we spend time with our patients, and we make sure that we know what our patients' goals are so that we can obtain those if they're obtainable.
And so there is a form of injections, but specifically your practice works with pellets, correct?
Well, we do injections and gels and creams and pellets. We do all modalities of testosterone replacement therapy. So I don't want to turn any guys off if they if shots is what they want. But I will say my preference is pellets. And many times after I walk my patients through why it's my preference, many times it becomes their preference as well. But I certainly have patients on injections, gels, creams, the different ways of replacing. I'm well versed in all of it. It's just I've fallen in love with pelleting. And that's why, we actually run a pelleting training clinic over in Irving where we help train providers in the procedure of pelleting, but also, training doctors on why maybe it's a better option for many patients. But I will say this, there is no one procedure for every patient. That is simply not true, just like there's no one level that is for every patient. That's why we got to get to know our patients, figure out what their likes, dislikes, goals are, and come up with a treatment plan. If that treatment plan doesn't work, then we need to back up, come up with a new treatment plan.
So if I've been listening and I want to reach out to you and start this conversation, what would that look like, Dr. Kris?
Couple ways, about 3 ways. Of course, they can click or go to theresearchclinic.com. That's an easy way. Go to the website. You can peruse around. There was a really good guy that made our website. Might be Steve and his group, but see about the different things that we do. There's a lot of different tabs that you can click on that gets the consultation process started. They can also call, our which is on our website, but 817-599-9902. Those are the 2 easiest most common ways. We now have Lauren, who is one of my longtime assistants, working virtually for us, full time. And so when those come in, Lauren gets on the phone and, walks you through any questions or, issues you may have. And then if we're a fit, then we simply get you on our schedule.
And there's no dumb question, right?
Correct. I really don't think there are dumb questions. And I, most of the time, whenever I sit down with a patient and they ask me a lot of questions, it makes me feel engaged with the patient. They're actually thinking enough that they're concerned. It always concerns me when patients like, nope, no questions today. And I'm like, wow, really? We just went through a lot. Like, no questions. I mean, I think I'm okay at this, but man, that's putting a lot of pressure on me that I'm that good. So I like questions. I really do. We have another saying in our clinic. We never want a patient to leave our office with a question in their head if they asked it. Okay. Now, if they don't ask it, that's on them. But if they asked it and I still did not answer it effectively, then that's on me and my providers. We need to basically keep answering that question in different ways until the patient feels comfortable.
All right. Perfect, Dr. Kris. Excellent conversation. I think it's definitely a lot of folks that need to have this discussion with their provider. And if your provider maybe, I want to point out that the difference between you and other providers is that there's an expectation that your patients are going to take responsibility in their health journey. And this is not an insurance pay type conversation as well.
Yeah, and I would actually say this is a relationship that we both have to be good with. And what I mean by that is I do let patient, I don't fire them from my practice, but I will say I don't think this is a good fit. Because if their expectation is I'm going to fix everything for them, but they're not going to put in any work, then it's probably not going to be a fruitful relationship. The good news is that's pretty rare in my practice. My patients kind of know there's expectations. Also, when somebody is paying out of pocket, I think it puts some skin in the game. It makes you concentrate a little bit more versus I paid a $20 copay. Who cares? I paid more for that for lunch today, and I really do believe that. And I also know, I get some patients like, well, they're uncomfortable with the whole like cash pay system. They'll see the difference when they come in. They'll see the time that I spend with them and my providers spend with them. I hear it at least once or twice a day. You spent more time with me today than my last doctor did in probably 2 or 3 years when we get new patients, because our new patient visit's quite intensive. And guys, there's a lot of great providers around this country doing what we do. We're not the only ones doing what I think to be a very good job. Even if patients aren't in our area, but a lot of times still reach out to us. Maybe you're in a state that I know somebody, because I know a decent amount of providers. We're more than happy to connect people to people that are in their area if we're not a fit geographically. So don't use that as a reason why you don't reach out to us. Maybe we have a license in your state, but if not, maybe we can refer you to somebody that is like-minded.
All right, excellent. I'm going to run our outro, okay? Thanks for joining the Dr. Kris Podcast. If you learned something today and you want to connect and get more information, visit our website, www.drkris.life, where you can find more great information or even schedule a time to learn how you can engage with Dr. Kris. Be sure to follow, like, share, and we'll see you on the next episode of the Dr. Kris Podcast. Well, good job, Dr. Kris. We look forward to having another conversation. We ought to do this more often.
Yeah, I know. It's been a little busy here lately, but we'll try to do them more frequently.
All right. Well, that's a wrap. So I'm going to end it. Do the awkward smile.